we have just had in the last hour, and it was with the Discovery Health CEO, Dr. Ryan Noach, who says there is a medium to short-term risk to the country's healthcare system when the National Health Insurance Bill is ultimately promulgated. Noach says, although the NHI is 10 to 15 years away from implementation, what's concerning right now is that who will fund it?
There are broad financing references in the current draft bill which talk to taxes that every South African would have to pay to contribute towards the NHI. And in their commentary, the Department of Health refers to the fact that, you know, the private sector and the public sector combined currently contribute about 8.5% of GDP towards the cost of healthcare.
Yeah.
And they assume, and I should add quite naively, they assume that this 8.5% would just be redirected into a national health insurance scheme. But quite clearly, that's obviously not how it could work. And there would need to be an act and regulations to support how it would be financed.
Well, let's get a response on this now, and perhaps an update from government as to where we are in the implementation of the NHI. And we're joined by the Deputy Director General at the Department of Health, Dr. Nicholas Crisp. Doc, thank you very much for your time. You have heard the sentiment from Discovery Health CEO, Dr. Ryan Noach. What's your response to the funding concerns around NHI?
Yeah, thanks very much, and good morning to the viewers. So, Ryan's entitled to his own views on this. We have already 265 billion rand that are in the public sector, so that's about 49% of what is spent in healthcare is already in the public sector. Now, the question is how we move the remaining 51%, because at the moment we spend about 5 times per person in the private sector what we spent in the public sector. So how do we get a more equitable distribution of that resource, and is that even the amount of money that is required? So there's some suggestions that that is already more than we need, and that it is removing the waste in the system. So that's what we need to concentrate on. So the question is, and there Ryan is almost right, is how one starts to move those various compartments of money. Even in the public sector, there will need to be the moving of conditional grants and the moving of some of the provincial equitable share. And those provisions are already in the National Health Insurance Bill. Now, over time, there are mechanisms already existing to move some of the money in the private sector, or that is spent in the private sector. The public sector spends just over 90 billion rand. It's subsidizing its own workers' medical schemes. And that money could be moved without new legislation. Obviously, it would require negotiations with the various social partners, but the unions have been largely in support of the NHI, and so moving that money into the fund and purchasing from the fund would be one of the things that needs to happen. There are other pockets of money that are spent in various parts of the private sector that will move as well. So he's quite right, it will take time, and these things do need to be phased in over that period of time.
Well, let's talk, Dr. Crisp.
We are less concerned.
Dr. Crisp, let's then talk about those monies from various parts of the private sector that will be moved into this NHI fund. Which parts are those? Because I suspect that's what they are going to quibble about.
Sure. So just today there were reports in the media about people leaving their medical schemes, and there was a whole discussion about it yesterday as well. And we've watched for some time how medical scheme members are migrating down from comprehensive packages into hospital care packages and less sophisticated packages, because they just can't afford the costs of the current medical scheme, that the membership fees that they pay, and because they are paying more and more out-of-pocket expenditure because things are not covered by medical schemes. So the private sector has just become too expensive for the majority of people to manage. So people like me will, as soon as benefits are covered by the NHI, will definitely not rely on medical schemes for our healthcare. We will move and pay the increase in tax if it's 5,000 Rand a month, it's 5,000 Rand a month that I will pay into the additional taxes to be able to fund my contribution to the national health insurance. That, again, does not happen overnight, and there are provisions in the bill that will require a money bill when monies do start to move. But I think Ryan is running ahead of us by years and not seeing how the changes need to happen.
Well, here's a direct contradiction to what you've just said. Dr. Noach claims that, contrary to what you have just said, that there are reports suggesting that people are downgrading or downsizing simply because of the unaffordable cost of private medical schemes. At Discovery, he says they have seen a growth, an upward cycle. So are you saying that he is not entirely being honest when he says they've seen a growth in people wanting to be members of private medical schemes?
Well, I can't say what the figures are doing in Discovery or in Discovery administration, but there are 76 medical schemes. And this morning's report and the figures that we see from the Council for Medical Schemes suggest that that's, even if that's what Discovery is seeing, that's not what's being seen entirely in the marketplace. We know during COVID a lot of people lost their medical schemes and some of them might be going back. But whether there's a complete growth in that market space, I doubt. And it's being complicated by the fact that there are more and more insurance products which are being launched, including some from companies who own medical schemes or run medical schemes as well. So I think this is a complicated financing market, and what we are trying to do is to simplify it, simplify the packages, and extend healthcare. What we are interested in is patient care. We're interested in outcomes, and we can't have a system where we provide one kind of healthcare for rich people, one kind of for poor people, and we can't afford to sustain either of them, and we are not getting the outcomes that we should be getting. Yeah. So we do need to shift the way in which we reform the health system, and I've no doubt that it's going to take a long time for us to get a proper equilibrium.
Well, here's where the rubber hits the road, so to speak, Dr. Crisp, and you'll indulge me a little bit here. The Minister of Health has said that some 200 billion is needed to fix the infrastructure in order for the NHI to, I guess, be implemented over time. And just that admission alone compounds what Dr. Noach refers to as medical practitioners in the public health care institutions who are absolutely frustrated, and if anything, they are starting to leave if they have not been leaving already because of just the kind of pressure that they are under. And so the question is, why is there so much optimism from your side that this is indeed ultimately going to be a success?
Yeah, so I mean, look, let's just wind back and see what I said a moment ago. We spend 5 times per capita on the private sector what we spend in the public sector. So that, put it in numbers. We spend about 5,200 Rand per capita in the public sector. That's what the Treasury allocates to care for 85% of the population. The remaining 15% of the population, we spend over 27,000 Rand per capita. You can't provide the same level of care. You can't maintain the facilities in the same way. You can't sustain a situation where we get a cut in our budget of 1.5% this year while the medical schemes increase their tariffs and get a tax subsidy. So, I mean, it's definitely got to be reversed, and we need to make sure that we are spending the money appropriately. Now, in the private sector, we know that from the Health Market Inquiry that about 15% of everything that is spent in the private sector does not go to healthcare at all. It goes to paying for administration. It goes into the profits of companies, and it goes to the administration of the money. Only after that do you start providing healthcare. And in that healthcare, we know also from the very Health Market Inquiry that there's massive over-servicing taking place in the private sector. Some of it is structural, and that's what we need to correct, and we're busy working on that now. We don't need NHI to be correcting that. And some of it is because people are forced to over-service because they are in a highly competitive space. And the only way to make sufficient money and to care for themselves is to do what I would regard as rather marginal care, which doesn't necessarily have good outcomes. And again, the health market inquiry has referred to many examples of this, grommets, tonsillectomies, cesarean sections, and so on. So I think it doesn't matter that whether we are right by 1% or 5% or 0.5%. The fact of the matter is there's a massive imbalance, and we are not getting good health outcomes, and we're not providing good health care in the country for the amount of money we're putting in. We definitely need a realignment.
Dr. Crisp, it's a no-brainer that the NHI and the intentions here are good. It's exactly what you're talking about, that there is a huge imbalance. But there's a problem with the public healthcare sector. And that problem starts with medical practitioners that are said to be leaving out of pure frustration with whether you talk infrastructure or I'm not sure what else is there that is causing them to leave. Are you suggesting that it is scaremongering or it is misinformation that doctors are leaving the public healthcare institutions in droves simply because they are frustrated?
Well, the numbers suggest that it's not droves, but there are people that are leaving, and I don't blame them for getting frustrated with the current situation. I want to repeat, if you keep underfunding a health system, if you keep restricting the filling of posts because there's no budget, if you keep on suppressing and making it impossible for the administration, notwithstanding the realities of corruption and fraud which we are dealing with, if you keep on trying to get blood out of a stone, there's no doubt that some practitioners will leave. And I have empathy with that. But they are going into a private sector which is saturated, and many of them get frustrated in that space as well. And there are people just frustrated with South African society who are leaving the country. But there are also people migrating into South Africa to provide healthcare. There are 2,760 new graduates every year as doctors in this country. So this is a complicated space, and I would caution against being oversimplistic. We are not denying any of the challenges, and the minister was quite correct. We costed the total overhaul of all the infrastructure at 197 billion rand. That is true. But if you remove that pressure by the fund purchasing healthcare from private providers, and by the way, we know of private hospitals that are sitting under 30% occupancy on many days. If we are able to redirect patients and the fund is able to purchase for public patients in those private facilities, which is provided for in the NHI bill, then you can decompress these many over-serviced or over-packed outpatients departments and facilities in the public sector. The point is, if we share the 400 public hospitals with the 265 private hospitals and look after people at the nearest place to where they live and not because they have money, we can definitely, and there's many models about how this has been done from one community to the next, and there are examples of it working at the moment with private hospital groups, especially the three big ones. So I'm not suggesting this is an easy free ride, but it's also not going to happen in 1 year. And there's a lot of scaremongering that it's going to happen next year. It's not. It's going to start once the bill becomes an act, and then we will slowly but surely build on what we are able to do with the funds available at the time.
I quickly want to ask you about when you think it is that this bill will finally become an act. In other words, will become law, but that will come in a moment. Do you think, Dr. Crisp, there is hope for this single NHI fund that will be managed by the state, which will buy health services from both public and private? Do you think there is hope for the existence of these two systems if indeed NHI does become law? Because Ryan Noach seems to think this is something that has not succeeded even from outside our borders.
Well, obviously, I wouldn't be doing the job I'm doing if I didn't believe it's possible. This is not the first time we've gone through major reforms in our country, and I was privileged to be part of the reform in 1994 when we were told we would never get rid of the homelands and we'd never be able to create a new South Africa. And look how we actually did manage to do that in a very short space of time. There are other examples of things that I've been involved in both this country and other African countries where everyone said it's not possible. Nothing is impossible unless you don't make it possible. The problem is where a company has a business model that is going to be impacted negatively by a reform, they are likely to find ways to try and defend the status quo. Of course, I believe that we need to do this, and of course, I believe we can do it. We do run big public entities in South Africa that already handle way more money than this, like SARS, for instance, and we do run the pension payment system through one big government agency for millions and millions of pensions every year. So it's not that the state is unable to run these kinds of services. Of course, we need to create the capacity to do it. But you could ask Dr. Noach and his colleagues, when that discovery was started with 50 or 60 employees way back 25 years ago, did they imagine what they would be today? And did they know exactly that it would look like it looks like today?
Yeah.
You never know that. You build from scratch, you build from small, and you improve. But we as a nation have got to get our act together, we've got to stand together, and we've got to look after all 61 million people, not the 15% who have money.
Yeah. Here's a final question. You have made the admission, just as we were told by Dr. Noach, that the implementation of NHI is a long way away. He says 10 to 15 years. And you've made a similar admission. But the first step is getting the bill passed in order for this to become law. There is a year that we understand that this bill is now going to be processed through, including the National Council of Provinces. By which time? Do you think there is a timeline that you can put your head on the block and say, by this time, the NHI will effectively become law in South Africa?
Well, let's take the time frames that we know and let's look at the unknowns. So the first thing we know is that the bill will be voted on in the National Assembly this afternoon, and we fully expect the bill to be passed in the National Assembly. And that is what we call the B bill, the one that's been revised after the past year of discussions and negotiations and considering inputs by the politicians who provide oversight in this country in the Portfolio Committee.
Yeah.
So that's the first step. Then it gets referred to the National Council of Provinces and it will go to the provincial legislatures. Don't know the time frame that they will be given by the NCOP, but we are expecting that before the year-end recess, so somewhere around October, November, it will come back to the joint houses for a vote once more. So assuming that it is voted into law at that point, that is the point at which the president could sign it into law and then begin to bring the various clauses. Because the way it's written, of course, it doesn't all come into law at the same time. The president brings clauses in to create the board and then to create the advisory committees and so forth. So that is the shortest time frame that is possible. In the meantime, we are building the capabilities in the National Department of Health. And in fact, we have very good cooperation with the majority of private players who know that there are going to be reforms and are fully expecting the changes. We're in this together, and there may be things we're going to differ on, but there are a lot of things we actually agree on. Whether it will be challenged and how it will be challenged in court, well, that we'll deal with when the time comes.
Yeah. Okay. All right, Dr. Crisp. I'm out of time, but there is a niggling question around it not being budgeted for by National Treasury. I mean, I was reading a report, just as you have been saying you've been reading reports, suggesting that there isn't even a paper from Treasury to say this is how NHI will be budgeted for. Do you think you can answer that in less than a minute?
Yes, sure. So those who attended the Universal Health Coverage Day on the 12th of December last year would have heard the WHO telling us not to do that and not to try and predict what the economy will look like or the rollout will look like over a 10, 15, 20-year period. They warned us just to get started and to work within the envelope that we've got and not to waste our time trying to predict what the environment will be like in the long term. We will work within the envelopes. Treasury has allocated 265 billion rand this year to the health system, and that is in the government purse. We need to work with that as a start, and as we move forward and as we build the capacity, we will see what other funds need to be brought to bear to make this a reality.
Dr. Nicholas Crisp, the Deputy Director General at the Department of Health. Thank you very much for the clarity. Very, very clear indeed.